Madam is joining, Guru. Just 2 minutes.
Yes, Ravi.
Madam, can we start, madam? Chandra, madam, can we start, madam?
Yes, we'll start.
Guru, can you make madam as co-host? Madam wants to share the screen and all.
Yes, Dr. Ravi, I made SR Chandra madam as a host. Madam, can you share your screen?
Madam, can you just start sharing the screen,
I'm
madam?
sharing the screen.
Yes, ma'am. Yes, Guru, please start and Srisha will take over.
Yes,
you.
yes.
Thank you. He's just checking the screen.
Ma'am, we're able to see the screen now. Shall we start, ma'am? I'll first of all, I will like to
Start.
introduce, welcome you all. Yes, shall we start, ma'am? Introduce
Yes,
the moderator, ma'am.
I am audible.
Welcome you all
Am I
for
audible?
weekly seminars. Yes, ma'am. Yes, ma'am. You're audible, ma'am.
Shall I start? Shall I start?
Ma'am, yeah, ma'am, 1 minute, ma'am. I will introduce the moderator for these sessions. Then we can start over, ma'am. Welcome you all for weekly seminar series by ONS and Indian Psychiatric Society Karnataka chapter. Today we have with us Dr. Shisha, a junior resident at Kempegoda Institute of Medical Science. Madam is going to put session and take over the session from now. Dr. Shisha, please.
Yes, sir. Thank you, sir. Thank you, sir. Yes, sir. Thank you, sir. I'll continue from now on.
Take over and.
Yes, sir. So I welcome you all. A very good afternoon, first of all. And I welcome you all to this Indian Psychiatry Society Karnataka chapter online neuroscience education. This is a neuropsychiatry webinar series for postgraduates and psychiatry and neurology. I would like to introduce Professor S.R. Chandra, ma'am. Good afternoon, ma'am. She is a former professor of neurology in NIMHANS, Bengaluru. She has been conducting these sessions since 3 years. It's an honor to be a part of this program, ma'am. Thank you for giving this opportunity to moderate today's session. I would like to welcome every one of you today. And if you have any doubts, kindly post your doubts in the chat box. And let us be interactive at the end of this session. I hope everyone will learn for sure some new thing today. And let's start the seminar, ma'am. Thank you so much.
I shall make a brief presentation on some of the EEG pointers in helping us to diagnose the border zone symptoms, because as you all know, so the neurology and psychiatry are one and the same only. So why border zone symptoms? Limbic system is a highly connected region of the brain, involving structures around the interventricular foramen and extends up to the brainstem. So dorsolateral prefrontal cortex monitors the limbic function with reference to culture-based social cognition and behavior. So border zone symptoms are part of the brain function or dysfunction when there is a monitoring failure of the prefrontal lobe on the limbic structures, or altered monitoring of the limbic structures by the prefrontal cortex. So this extensively connected, and the whole brain is extensively connected. Even though we feel that the frontal cortex is monitoring the limbic structures, the whole brain is extensively connected with the limbic system. So the dorsolateral prefrontal circuit is an important circuit. We have first in the anatomy session and physiology sessions, we have gone through this. I had only presented in the initial sessions. So this is a very important circuit in the border zone symptoms, which connects the dorsolateral prefrontal cortex with the pallidothalamo-cortical pathway, and it is involved in motor planning, organization, deciding which stimuli to attend to, shifting cognitive sets, and sequencing, attention span, and working memory. So other frontal circuits are medial and lateral orbitofrontal circuit, just for a quick revision only, concerned with learned social behaviors and inhibitions. And cingulate circuit is for physiological obsessions, and amygdala circuit behavior like aggression and agitation. So the each lobe has got border zone symptoms, and it, as you know, frontal lobe is personality, social cognition, executive function, choice, selection, response, inhibition, and socially appropriate behaviors. And the temporal lobe is for auditory perception and its alteration. Parietal lobe is for sensory perception and its modifications, and occipital lobe for visual perception and its modification. All these can be present with the border zone symptom. And brain thinks and is responsible for memory, intelligence, and thoughts, and controls autonomic functions like heart rate, breathing, homeostasis, controls immune system, regulates hormones, and regulates every other system. So you have a variety of symptoms can arise from the brain and confuse the clinical problems. So limbic lobe is a part of the cortex on the medial side of the hemisphere, consisting of subcallosal and cingulate and parahippocampal gyri, which we have already gone through in the earliest first session. And hippocampal formation consists of the hippocampus proper, the Ammons horn or the cornu ammonis, the dentate gyrus, the subicular complex, subiculum, presubiculum, and the parasubiculum, and the endorenal cortex. So unlike every other organ, the limbic organ is very big in the lower animals because they act by impulse. Whereas in limbic organ is becoming smaller and smaller and shrunk and buried in the evolution in humans. So now we will see how EEG is going to help us and some common problems to differentiate when we are in confusion. So epilepsy, we want to know whether it is epilepsy or non-epileptic attack, or there can be a combination of both in the same person. And is it a localization related epilepsy presenting with an odd clinical symptom? Is it a condition like Lindau-Kleffner syndrome where the patient is mute and not communicating due to seizure and not catatonia? And what are all the role in understanding non-convulsive seizures? And then other common conditions like dementia. Is it a true dementia or pseudo dementia? And what is the role of EEG in early changes in FTD, AD, and DLBD? And prognostication, that is identifying the rate of progression in a cheaper method by EEG scoring. And diagnosis of rapidly progressive dementias, immune-mediated dementias, mass lesions, which can all have an array of neuropsychiatric symptoms. Then what changes happen in delirium, catatonia, coma, metabolic encephalopathies. So we'll approach this one by one. So epilepsy, what happens in true seizures? Interictal EEG may or may not be normal. So the description may be bizarre, and interictal EEG is normal. So we have to be careful to see the attack to make a diagnosis. And ictal EEG is always abnormal. And video EEGs are very diagnostic. Same person we know that pseudo seizures can complicate true seizures. It can complicate major mental illness. It can complicate minor mental illness, or it can just be an episodic discontrol syndrome or completion phenomena in a cured epileptic. So all these coexist. So we have to be very careful. Even in an epileptic, some of the attacks may be non-epileptic. In those situations, video EEG is very diagnostic, because true seizures and pseudo seizures can coexist. So we may be unnecessarily going on increasing the dose of the anticonvulsant. So it is very important. And endogenous event-related discharges, which decline with disease control, is seen in some cases of non-epileptic attack disorders. So a person may have non-epileptic seizure, and we have seen many patients, and this observation, we got some award in the Ranchi conference, because some patients were being treated as epilepsy, the reason being a highly abnormal EEG. But seizures when witnessed were pseudo seizures. So what was happening? So we tried to find out, and we identified serious psychological stresses. And when the stresses were addressed, the EEG became normalized. So this term was coined with reference to epilepsy, and this paper was presented in Ranchi, and we got the best paper award for that. That is, endogenous events can produce EEG changes. So dilemmas with interictal EEG: single EEG may be normal in 30% of people and prone for circadian fluctuations. So it can be misleading in 10 to 20%, either way. And focal attenuation of normal activity can sometimes be a soft EEG sign. And rhythmic activities can also be normally seen. And rhythmic spike and wave discharges have to be viewed again with a clinical correlation. And focal slowing like rhythmic theta, phase reversal, spikes, slow waves, sharp waves may be seen in generalized seizure and vice versa. So other features, features of frontal lobe seizure is one condition where it closely mimics the pseudo seizures, because it can be very brief, occur several times a day, odd posture, they can have fencing posture, pelvic thrust, they can have retained inner awareness, and very bizarre out of phase movements like figure of 4 movements. So this can closely mimic frontal lobe seizures, can closely mimic a pseudo seizure. And it can also present with just a change in the mood or affect, autonomic features, and abnormal gesturing, which is seen in lesions in the cingulate region, and forced thinking, axial clonic jerking is seen in frontopolar region, illusion, hallucinations, and gestures are seen in orbitofrontal region, and figure of 4 posturing occurs in the tonic phase of frontal lobe seizures. Bicycling, pedaling, and sexual and vocalizing movements can be seen in frontal lobe seizures. And some of these patients, unlike the classical seizures, where there is amnesia for the event and inner consciousness is lost, the frontal lobe seizures, they can have inner awareness. So all the more we are tempted to think it is not organic. And ictal EEG is diagnostic, and video EEG shows stereotyped attacks. So in those situations, the attack phenomenology is nobody can create the same figure of 4 posturing every time a pseudo seizure is coming. So stereotyped motor phenomena and abnormal ictal EEG will help us to say that this kind of mood fluctuation, forced thinking, hallucinations, and posturing, all that can be organic, and it will respond to treatment with anticonvulsants. So this is a typical frontal lobe EEG spike and wave discharges are seen in the bifrontal region, bifrontal spike and wave discharges seen in a frontal lobe seizure. This is an interictal EEG. And this is another person showing a epileptic discharge in the frontal lobe. Frontal lobe seizures are very often because pelvic thrust, fencing posture, all these and retained inner awareness several times a day, wake up immediately without any confusion. So all this will create a lot of confusion in diagnosis. Next, we will come to temporal lobe seizures. So ictal dystonia. So sudden abnormal posturing can be an ictal phenomena. Ictal whistling. Suddenly the person whistles and we don't know whether it is a seizure or not. And so this can happen in medial temporal epilepsy. Then auditory, olfactory, autonomic, emotional, vertiginous, and these kind of movements can happen in superior temporal lobe. So this very closely, these can be mistaken as in the border zone. Gustatory movements, clonic movements of ipsilateral face, salivation, simply salivation, nothing else accompanying, spitting, retching, vomiting, all these can be seen in opercular region seizures. And dreamy state, deja-vu, jamayu, jamayetandu. So sometimes feeling that you are in an unfamiliar place, you feel familiar, or reverse, in a familiar place, you feel unfamiliar, or you feel that your conversation that is going on has been heard before, or you feel that you lived through a previous era. And forced thoughts, past life experiences, all these can be narrated by a patient as a ictal phenomena. And they can have running attacks, rotary attacks, and wandering attacks. All that can be seen in the border zone. So it's suddenly running, suddenly rotating, and wandering, and with climbing amnesia. Who brought me to this place? I don't know. So all these are difficult symptoms in the border zone of epileptic nature. So here we can see the phase reversal. You see the phase reversal at T2, anterior temporal phase reversal. So that way EEG will help us. Then these are discharges in the anterior temporal lobe again by interictal discharges in the temporal lobe. So this is an ictal discharge. How does an interictal discharge differ from an ictal discharge? Interictal discharge will show a build-up, starts in the temporal region. Same area, same patient. It starts in the T2, and as beta fast activity increases, the discharges increase in frequency and amplitude and goes on increasing and culminates in a ictus. So ictal EEG is more informative, but interictal EEG itself can give a lot of information most of the time. So temporal intermittent rhythmic delta. So that may not be typically the spike and wave. So temporal intermittent rhythmic delta, sometimes we may pass it off. So this indicator, this is an important thing you can find in patients with the medial temporal sclerosis. So not the classical spike and wave, it's called TIRDA. So these are again showing phase reversals in the T3. We saw phase reversal anterior temporal, temporal polar. Now coming towards the mid-temporal discharges. And this is a beta fast starting from the, we saw the beta fast starting from T2. And this is a beta fast starting from T3 and goes on building up in frequency and amplitude. And this is little more posterior temporal, T5. So these patients who are just showing gyratory movement, rotating, laughing, whistling, all these patients, they claim amnesia for the event. It is very important that we do an EEG and it will give us clues. Then occipital lobe, stereotyped formed visual auras or unformed auras. Some people how told that a snake is seen every time. The patient gets frightened and then becomes unconsciousness. So they will think that a patient sometimes saw a snake, he got frightened seeing that, and after that he imagines the snake and becomes unconscious. So it is an occipital lobe aura, which can be either formed or unformed. Usually it is stereotyped. Ictal aura in occipital lobe is always the same. If you see a snake once, every time it is only a snake. All the more it is mistaken as non-organic. And you can have micropsia, macropsia, metamorphopsia. Seen world might become small, big, or mixture of small and big, and hallucinations of colors. All these are border zone symptoms. And you see the EEG shows discharges in the temporo-occipital region. You can see the O2, O1, and here it is going in the temporo-occipital region. You are seeing discharges. And this is monopolar leads, again showing discharges in the temporo-occipital region. Here also you are seeing the ictal discharges in the temporo-occipital region. So these patients who have got this stereotyped aura, we can pick it up with the EEG. So what are all the parietal lobe border zone symptoms? Sensory march, Jacksonian march of just a sensation spreading, or a pilomotor attack, sudden sweating. So pilomotor attack is a goose flush and sweating in some area which comes as a march and goes away. You don't know what is happening and you think it is due to some panic attack. Goose flush and sweating can happen in a parietal lobe, which can be closely mimicking a psychogenic symptom, and a sensory march. So these are this can be parietal lobe ictal phenomena, and the EEG will help us by showing the ictal discharges in the parietal region. Then we can see rhythmic spikes. So these spike and waves, so rhythmic spikes with the spike and wave discharges, very classical, seen in the left parietal region, and also in the temporoparietal, in the temporal region and the temporoparietal discharges. So sensory march, pilomotor, panic-like features can be easily picked up with the EEG clues. So this is a Lindau-Kleffner syndrome, where the child remains uncommunicative. Sometimes it can go on for hours to days. We can mistake it as a catatonic non-communicating situation, because we may find a normal MRI, we may not be able to demonstrate many other things. Why is the child not talking? So we get confused, and then you do the EEG. It is having a classical pattern. They have asymmetrical discharges from independent from both hemispheres when they are awake, and these discharges become symmetrical when they are asleep. So this is typical Lindau-Kleffner, where the child can be mistaken as catatonic stupor. Then next we will come to the non-convulsive status epilepticus. It can present with a variety of symptoms, altered mental status or abnormal behavior. So there is no convulsion, so it's all the more difficult, and altered mental status or abnormal behavior, unexplained stupor in a recovering patient. Patient is recovering from meningitis or something like that, and he has an unexplained stupor. The hallmark of non-convulsive seizure is a change in the behavior or mental status that is associated with the diagnostic EEG changes. So EEG changes with a neuropsychiatric change in a patient who is recovering. And usually, what are all the possibilities considered? Critically ill patient developing an ICU psychosis. So we may think, okay, this person was sick and he is developing an ICU psychosis. That is one possibility will commonly considered. Or a recovering patient going into depression, and or the person consumed drugs. We have seen patients who somehow managed to consume drugs inside the ICU itself. When they are recovering and knew what happened to their health status, we have seen picked up some patients. So all this will become differential diagnosis, or is the person having a metabolic encephalopathy or non-convulsive seizures. So when a critically ill patient who is recovering is going a neuropsychiatric syndrome, all these differential diagnoses will come, and EEG will be helpful for us to differentiate. Other features of non-convulsive, so what are all the clinical features of non-convulsive seizure? In a neuropsychiatric syndrome happening in a recovering patient, what are all the other features? They can present with a mild cognitive disturbance, like impaired attention, difficulty in sequential planning of complex motor tasks, prolonged confusional state, mood disturbance, psychotic behavior, speech disturbance, verbal perseveration, reduced verbal fluency, muteness, speech arrest or aphasia, bizarre behavior that is uncharacteristic or deviates from baseline, for example, laughing, dancing, singing inappropriately, repetitive motor activity, autonomic disturbances like belching, borborygmy, flatulence, which are looking like a not explained by that particular organ related pathology, and sensory and psychic phenomena and coma. So these kind of varied symptoms can be a manifestation of non-convulsive status. And no criteria to guide the decision of when an EEG should be requested. So when these symptoms are seen, we can, if you have ruled out electrolyte imbalance or drugs or recurrence of the same infection, things like that, we can order for an EEG. And the types of EEG changes are non-specific. So we cannot say, you see this EEG change, this is non-convulsive seizure. So that pattern is not there, but continuous or nearly continuous generalized rhythmic bilateral synchronous spike and wave discharges can be seen. If they are seen, we are happy, but unpatterned EEG discharges, which are not expected at that context, will also be a pointer to non-convulsive status epilepticus. Then we'll come to true dementia versus, so some of the bothersome symptoms in epilepsy and non-epilepsy and neuropsychiatric manifestation of true seizures. All this we have briefly gone through. Next we will come to pseudo dementia versus true dementia. These are sometimes very difficult because the usual MRIs when the person is going into early dementia may be misleadingly normal also, or an widened sulci and gyri can be seen in normal persons. So we have some difficulty many times. So what is the way in which EEG will be helpful? There is a thing called contingent negative variation or expectancy wave. Patient may have some motives. So we do the EEG to find out whether this is there. So indirectal qualitative and quantitative EEG can be normal, and then patient is given a 3-stage command with a threat. So you give a 3-stage command with a threat. When the bell rings, you have to press the button, and if you don't, you will get a shock. This is the command. These kind of commands are given to elicit the contingent negative variation or expectancy. So a patient with a true memory loss will forget the command. So EEG goes on as baseline. But a patient with no memory loss remembers the command and expects the shock. That produces a high amplitude delta discharge called expectancy wave or contingent negative variation, which used to be used in the pre-video EEG era as one of the markers to identify pseudodementia. And of course, we know the various points to differentiate pseudodementia from true dementia, of which expectancy wave in the EEG is one of the things which used to be practiced in the older times. Now we have got evoked responses, PET scan and other things, so we do not routinely use this. Then to differentiate FTD versus AD, is the EEG useful? Normal or reduced frontal beta Normally in the EEG, we know that beta anteriorly and alpha posteriorly. So normal or reduced frontal beta is seen in frontotemporal dementia. Reduced posterior alpha is seen in Alzheimer's disease. And quantitative change in the brain volume can be assessed by a cheap alternative to voxel-based MRI repeating by Jongman score in the EEG. So here you see a classical case of FTD, closely resembles a neuropsychiatric syndrome. Frontal lobes are gone. And they can have uninhibited behavior. They may be antisocial, hypersexual, obsessed, wandering, and environmental dependency. So simply responding to any environmental stimuli without social cognitive barriers being respected. So these and they can have irritation of and other behaviors like displayed anger due to dorsomedial amygdala, and destruction of amygdala will produce a cucumber-like patients. So other way, destructive lesion of the amygdala, and lesions of the dorsomedial nucleus of thalamus produce docility and placidity, and lesions of the ventromedial hypothalamus produce aggression. And this is utilization or the environmental dependency. And we can see the temporal atrophy. You saw the frontal atrophy in the FTD, where frontal beta becomes suppressed and less fast and low amplitude, whereas AD we can show decreased amplitude and frequency of the posterior alpha. And what is this Jongman scores, which can be used as a substitute for voxel-based morphometry to measure, for example, a person with the subjective cognitive decline, self-complaint is there, or MCI, mild cognitive impairment. We say that one of the region point us to say conversion to dementia is serial measurement of the volume of the hemisphere and disproportionate volume loss. That is done by voxel-based morphometry. Instead, Jongman score can be applied in resource-restricted areas. The parameters are measured in a 20 minutes artifact-free EEG, and the parameters utilized are frequency of the background, amount of slow waves, the pattern of reactivity, paroxysmal activity, focal disturbances, and sharp waves. So these 6 parameters are assessed in a 20 minutes artifact-free EEG. This can be repeated any number of times, and this will help us as a cheap marker to know whether your subjective cognitive decline or MCI is converting into dementia. It's a 30+1 point score. Frequency 9 Hertz or more, you give 0. 8 to 9 Hertz, you give 1. 7 to 8 Hertz, that is a predominant ongoing rhythm, is the background rhythm. So the background rhythm is in these various frequencies. 7 to 8, you give a score of 2. 6 to 7, you give a score of 3. 4 to 6, you give a score of 4. And if the background is less than 4, we give a score of 5. Then for slow wave, there are no slow waves, the score is 0. Intermittent theta, the score is 1. Intermittent theta and delta, score is 2. Continuous theta and intermittent delta, the score is 3. Continuous theta and delta, score is 4. Continuous delta, the score is 5. Reactivity, normally reactive to eye opening or photic stimulation, it is 0, and hyperventilation. And decrease to eye opening is 1. Absent reaction to eye opening is 2. No response to pain is 3. No response to sound is 4. And no reactivity at all, the score is 5. Then paroxysmal activity, none is there, 0. Paroxysmal slow waves is 3. And for the frontal intermittent rhythmic delta, that is 5. And focal disturbance, you see nil, 0. Minor or unilateral, the score is 1. Minor bilateral, the score is 2. Severe unilateral or mild bilateral, it is 3. Severe bilateral is 4. And multifocal disturbance is 5. And sharp waves, none is 0. Sporadic sharp waves is 2. Frequent sharp waves is 3. And triphasic waves is 4. And 1 per second periodic waves is 5. So all these are put together and the score is made, and that score is kept there, and you repeat it after in a person with MCI or SCD, and repeat it after 3 months or every 3 months, and you find that the score is deteriorating very fast, then you know that this person is converting to dementia. And then next is the posterior parietal occipital lobe atrophy is a typical feature of DLBD. We see frontal atrophy in FTD, temporal atrophy in AD. Early phase of DLBD, EEG may be normal, but late you find occipital lobe is usually a resistant lobe, but occipital lobe involvement is seen in DLBD. And EEG in DLBD will show low frequency alpha, low amplitude alpha, and poorly reactive alpha. So these features with a typical patient who is having a visual hallucinations. So you know it is organic, and the visual hallucinations are due to organic problem. Then we will see the CJD. This is the typical CJD MRI with the inverted hockey stick, pulvinar, and the cortical ribboning. And this is the typical EEG 1 per second periodic complex, 1 per second sharp pace EEG we are seeing. So in our person with a rapidly progressive neuropsychiatric syndrome, you do the EEG and it will show this periodic complex. Then we are thinking it could be CJD, but it can also be seen in hepatic encephalopathy, toxic encephalopathies, autoimmune encephalopathies, but you have to correlate the clinical picture and then follow it up with the MRI. So this is not 1:1 CJD, it can be seen in reversible conditions also, like toxic, metabolic, hepatic, as well as autoimmune disorders. So next we will come to the dementia part. We have seen the changes which are helpful for us, and then we will come to the limbic encephalitis. Limbic encephalitis is a neuropsychiatric presentation, is the commonest because it's a limbic structures which is affected by inflammation. It may be infective, autoimmune, non-infective, seronegative, or paraneoplastic. These are the common causes for limbic encephalitis. This is a typical one, HSV encephalitis. But this can also not show the classical seizures, fever, and all those things may sometimes be lacking. And this actually belonged to a patient who attended the funeral of a loved one. And on coming back home, he was very sad, depressed, and showed a lot of behavioral changes. So it was easy to mistake it as a grief reaction, but this was his MRI. And EEG showed biplets. Unfortunately, I could not retrieve his EEG from my old records. So this is this shows biplets. So typical independent bihemispheric ictal discharges of 1 to 2 hertz is very typical of herpes encephalitis. And this is a non-herpetic, non-paraneoplastic lymphic encephalitis showing signal changes in the cingulate region and the insular region. And you can see the frontal plates. So spike and wave, it's a periodic localized epileptiform discharges which are bihemispheric independent is seen in herpes. They are called biplates. And non-herpetic limbic encephalitis shows frontal plates. This is a classical frontal plates. Then Hashimoto encephalopathy, we can present with a broad spectrum of clinical symptoms, not at all uncommon. It can present with seizures, myoclonus, cognitive decline, visual hallucinations, to paranoid delusions, and diagnosed on the basis of high index of suspicion because they may not show the overt features of altered thyroid function like hypothyroid or hyperthyroid features may not be there. And psychiatric symptoms and mild cognitive decline and a high level of TPO antibody and exclusion of other possible causes of encephalopathy and typical EEG findings. And reversal of clinical and EEG abnormalities upon steroid treatment. So this is Hashimoto encephalopathy. This is the MRI. MRI shows white matter changes in Hashimoto encephalopathy. And then NMDA encephalitis. We got other autoimmune NMDA encephalitis. A unique electrographic pattern characterized by rhythmic delta activity of 1 to 3 Hertz with superimposed bursts of rhythmic 20 to 30. So low frequency delta with a fast frequency beta riding on the delta. That is called extreme delta brush. So extreme delta brush is fast activity of a very high frequency riding on a slow activity of a very low frequency. Although it is not yet known whether the extreme delta pattern is specific for anti-NMDA receptor encephalitis, its presence in the correct clinical context should raise a strong suspicion of the diagnosis. Very slow, on top of that, very fast activities riding. Then EEG pattern in an unresponsive pattern, unresponsive patient. It can be alpha coma, spindle coma, beta coma, delta theta coma, and special situations and catatonia. One thing, if you have beta coma, in a person who is comatose, if the EEG is showing beta, we can be sure it is drug toxicity. So suicidal or accidental. So beta coma is a drug-induced coma, very useful in some situations. You don't know what to do with a comatose patient. They do not give the history. EEG shows beta. I can be very happy. It's not encephalitis. It is drug. Alpha coma, activity in alpha range, diffuse distribution. Normally alpha will be posterior, but alpha coma, alpha will be diffuse, anterior and posterior, and it will not show the reactivity. So alpha coma is a brainstem destructive, generally indicating a poor prognosis. Alpha is there anteriorly, alpha is there posteriorly, and it is unreactive. Spindle coma, throughout you are seeing sleep spindles. So this is seen in the hypothalamic region. So localization of a patient with coma indicate probably some pathology involving the hypothalamus. Beta coma is drug. And delta theta coma is the dominant activity in delta range is seen in metabolic encephalopathies or severe destructive brain disease. And special situations, mid-positive triphasic wave indicates metabolic, and PLUTS, as we have seen, autoimmune encephalitis. And in the class psychogenic catatonia, the EEG is normal. Whereas catatonia in an organic setting like catatonia due to autoimmune encephalitis, EEG will be helping us to differentiate. Catatonia can be psychiatric or organic, and EEG will help us to differentiate the organic causes for catatonia. Then we'll come to what are all the changes you find in delirious patients in EEG. So delirium is a brief altered sensorium due to a systemic cause usually. So sometimes very difficult to manage and very difficult to come to a conclusion what is causing the delirium. It can be infection, electrolyte imbalance, drugs, all those things. So there will be dropout of the alpha. Like, so alpha frequency declines and the alpha is non-reactive, and there can be generalized slowing, there can be occipital slowing, and persistent and prolonged slowing in a delirious patient indicates complicating dementia, which we call big clouding. A dementia patient, if his cognitive reserve is good and the cognitive demand is less, may be missed for a long time. He may be functionally okay. But when he gets an infection, he will go into delirium. So if that person has got a persistent EEG changes, you know that it is not due to a pneumonia or a hyponatremia. It is big clouding of an underlying compensated dementia. That we call it as big clouding. So big clouding, delirium can be a first manifestation of underlying dementia that is diagnosed by persistent EEG changes. Whereas other situations, other brief causes will manifest with alpha dropout, non-reactive alpha, generalized slowing, and occipital slowing. And EEG, when in psychiatric, when do we order EEG? When a person has got a psychiatric symptom. All psychiatric patients, we don't ask for EEG. So late onset psychosis. So it may be a big clouding, or you can do the Jonkman score. So to know early dementia. So late onset psychosis and refractory behavior problems. Behavior problems not responding to treatment, maybe autoimmune encephalitis. So refractory behavior problems. And first episode of schizophrenia like symptom after 4th decade. And quantitative EEG will help us to differentiate delirium of usual nature, dementia and depression. Then cognitive and developmental disorders. If they have a neuropsychiatric symptom on the background of a poor cognitive performance and a developmental delay, then you have to look for an organic cause and then we will ask for an EEG. And soft changes are very common in EEG, are not to be considered seizure from the EEG unless it is supported by a clinical feature. So late onset psychosis, refractory behavior problems, late onset schizophrenia, all these situations we ask. And when there is a neurodevelopmental delay, and quantitative EEG is very useful, but seeing some discharges in the EEG, we should not call that patient with a neuropsychiatric syndrome as epilepsy or anything organic unless it is supported by the clinical phenomena. EEG in psychiatric diseases has to be understood with the what happens in normal people. So healthy normal people can have abnormal EEG in 10 to 15%. And in schizophrenic patients, there is a high percentage of EEG abnormality. That does not point to organicity. And bipolar disorder patients show abnormality in the EEG in about 20%. Next, we will come to, so these things have to be kept in our mind, and each person has to be assessed on his own clinical, radiological, and EEG merit. And then EEG in metabolic encephalopathy, in grade 1 encephalopathy, almost it can be normal, but hyperventilation-induced changes come yearly and last longer. Grade 2, mildly abnormal with excess of theta in the background. And grade 3, moderately abnormal with continuous delta. And grade 4, severely abnormal with low amplitude delta, and you can also see mid-positive triphasic waves. And grade 5 is electrocerebral silence, slowing less than 2 microvolts. Then EEG in schizophrenia. So EEG in schizophrenic patients can show increased frontal beta. We said that is some kind of neuropsychiatric symptoms. Decreased frontal beta, low amplitude frontal beta is FTD, whereas increased frontal beta is seen in schizophrenia, and increased slow waves and decreased sleep spindles. So increased frontal beta, increased slow waves and decreased sleep spindles are seen in schizophrenia. And choppiness. So what is this phenomena called choppiness? Low amplitude, disorganized fast activity with reduced or absent alpha. This combination of low amplitude background with a disorganized fast activity, not the classical frontal fast activity. It is seen here and there. Drug-induced fast activity will be generalized. Normal frontal fast activity is in the frontal region, but disorganized scattered fast activity with reduced or absent alpha is called choppiness. And excess of slow activity, slowing of background activity, high amplitude beta waves, paroxysmal discharges, spike and wave discharges, and generalized slowing. All these can be seen in patients with schizophrenia, and they should not be mistaken as epilepsy. And as we know, increased activity in the nigrostriatal and mesolimbic system and decreased activity in the mesocortical dopaminergic system is the neurochemical basis of schizophrenia. So it is not surprising that the mesolimbic and the mesocortical alteration in the neurotransmitters produce EEG aberrations. So this is the choppiness where the beta is irregularly distributed, and the slowing of alpha frequency and high voltage beta, all these are seen in schizophrenia. And epileptiform discharges in psychiatric conditions may be seen in panic attacks, attention deficit hyperactivity syndrome, aggression, and autism. So ictal rage in is non-directed, unprovoked, and it can be associated with brief EEG changes. So all this is not, so we have to weigh all this in collaboration with the clinical data. And EEG slowing can be seen in acute confusional state, depression, alcohol intoxication, and post-concussion syndromes. So left temporal theta should not be mistaken as tirda. Medial temporal sclerosis, tirda is seen in MTS, but left temporal theta can happen in schizophrenia. And right temporal theta is seen in mood disorders. And 6 per second spike and waves are seen in MDP. And you may see positive spikes, small short spikes. And all these can be seen in psychiatric disorders. And chronic alcoholism produces irregular bilateral spikes. And impulsive persons can show positive spikes. And dyslexic children can show several abnormal patterns which are not really ictal. Small short spikes, 6 per second spike and spike and wave complexes, and positive spikes are seen in patients with suicidal ideation. And EEG is useful to identify organic catatonia from psychiatric catatonia. So this is the 6 hertz per second spikes. If you see it in a person, we have to think of a mood disorder with suicidal ideation. And psychiatric drug, what is the role of EEG? So monitoring psychotropic drug toxicity when we are using drugs like clozapine, and prediction of response to treatment. So for all this, EEG can be used. So clozapine, when the person develops epileptic discharges, we have to think that we may have to no further rise in the dose will be safe. Patient may throw a convulsion. And beta coma indicates drug overdose. And lithium can produce an EEG which typically resembles CJD. And slow waves, sharp waves, mid-positive waves, and periodic discharges can be produced by lithium. And EEG normalization in a person with temporal lobe epilepsy, then patient goes into psychosis. This is called forced normalization. With anticonvulsants, you can control the EEG discharges, and then patient goes into psychosis. So older years, we used to be taught that permit the person to have an occasional seizure. That will be the control system for the psychosis, but involves the risk of throwing a seizure in a risky situation. Then EEG biofeedback in treatment. Neurofeedback works like a natural anti-epileptic therapy and rewards brain for holding it in a particular frequency. I am not familiar with this. I have just taken it from literature only. And patients learn to produce the desirable brain wave pattern by biofeedback therapeutic mechanisms and corrects deficits in regulatory function related to attention, arousal, and vigilance. And beta state. Alpha state is commonly alpha meditation and all is familiar to us. And beta state improves arousal. So if the person learns by biofeedback to increase his beta discharges, it improves arousal and depression. And what is something called sensory motor rhythm, I will show that. And if the person can hold his EEG in a sensory motor rhythm, it improves calmness and relaxation. And left-sided sensory motor rhythm and right neurofeedback correlates with the dysregulation. And then if you have right side training helps in social and emotional contact disorder. So these kind of training techniques are, I am not familiar, but it is said that these biofeedback techniques can be a substitute for pharmacology. And this is the classical sensory motor rhythm, which will produce calmness. So sensory motor rhythm is an oscillatory ideal rhythm of synchronized electrical brain activity. It appears as spindles in recording of EEG. These things. And magnetic EEG and electrocardiography over the sensory motor cortex. For most individuals, the frequency of this sensory motor rhythm is in the range of 13 to 15 Hertz. And if the person is trying to keep his brain in this frequency, it is having a calming effect. So it is a pharmacosparing therapy in neuropsychiatric syndromes. And what are all the EEG changes in ADHD? You find that good number of patients will show non-specific EEG changes in ADHD. So now good number of patients with ADHD show patterns which are like cat on the wall, can be mistaken as organic or non-organic, but they are not really normal. And so indication for EEG in a child with ADHD is, therefore, if you find an EEG abnormality in ADHD child, there is no need to start anticonvulsants. So when do we order EEG in a child with ADHD? When there is a personal or family history of seizure and inattentive episodes of excessive daydreaming. It comes in an episodic or periodic pattern. If these some behavioral patterns are coming episodically or periodically, and episodic unprovoked temper or rage attacks, frequent recurrent headaches which are refractory to headache management, and history of head trauma, encephalitis or meningitis preceding the onset of ADHD symptoms, and abnormal neurological examination. If you find, you ask for an EEG. And limbic encephalitis, very often present with neuropsychiatric syndromes and mistaken, and an EEG will be very useful to say that this is in fact organic. And EEG can be normal, but we have to remember that EEG can be normal in organic diseases and abnormal in psychiatric diseases. And typical EEG findings in neuropsychiatric syndromes point to specific diagnosis, like Lindau-Kleffner, NMDA encephalitis. And soft EEG changes are common in psychiatric disorders and do not indicate organicity. And EEG can be used to assess efficacy, toxicity of therapeutic agents in psychiatry. And biofeedback-based training to keep the brain in a particular rhythm is of use in psychiatric disorders as a pharmacosparing agent. So that is all. So I have briefly covered the patterns. There are innumerable patterns which are in the border zone areas, which I have not gone through. So EEG has got a role in neuropsychiatric border zone symptoms. That is what I want to convey. Thank you.
Thank you, ma'am. It was really an amazing session. I hope we learn this is a very detailed session, ma'am. We learned very new things. And I request everyone, if they have any doubts, please post it in a chat box, or you can unmute yourself and ask.
Ma'am, I am Dr. A.K. Pandey.
Yes,
Ma'am, how to differentiate metamorphosia of migraine origin versus epilepsy, like micropsia, that also happens in the migraine.
Yes. So occipital aura, we will find, if you typically find the phase reversal or spike and wave discharges in the temporoparieto-occipital region, then we are comfortable. So clinically, the aura is followed by unawareness. Okay, that will point to a possibility of a seizure, especially in HIE sequelae. And you find a phase reversal or spike and wave coming in that region. Then it will correlate with a clinical feature and we'll try an anticonvulsant. Whereas the typical spreading depression of Leo producing the visual aura is usually followed by headache, but there is a condition called cephalgic seizures. Correct. Because headache can be a manifestation of seizure itself. Those conditions, EEG is more useful. Classical epileptic discharges are not seen, but migraine can produce slowing, non-specific soft EEG changes are seen during the phase of acute migraine. But classical phase reversal, spike and wave discharges followed by unawareness or seizure, that will clinico-electrophysiological correlate, and we will know that it is the occipital aura of epilepsy.
Thank you, ma'am.
Thank you, ma'am. Thank you, sir. Any other questions, please? Okay, so we don't have any more questions. Thank you, Chandra ma'am. It was an amazing session. Everyone, I wish you a very good day, and I hope you follow up the upcoming consecutive sessions. Have a good weekend.
Thank you so much. Thank you.
Thank you, ma'am.
Thank you. Thank you very much.